Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and Med Talks, I welcome you all to yet another wonderful episode of 52 Weeks of Diabetes Essentials with Dr. Sanjay Kalra. Today's topic is very interesting topic. It is rational antibiotic use in diabetes infection. And today's session is brought to you by your zero calorie hydration partner in Result Zero. Now, before moving forward, I would like to announce the last week quiz winners. So, Dr. Sanjay Shiroha from Surat, Dr. Bharat Praveen Mittakota from Surat, Dr. Anand Purande from Mumbai, Dr. Nakal Bansal from Panchkula, Dr. Ashutosh Das from Tumluk, Dr. Shashi Khare from Bhopal, Dr. Vinay Desai from Thane, Dr. Satish Kumar Jain from Bangalore, Dr. Sanjeev Puri from Hoshiarpur, Dr. Lakshmipati Bhupati from Vellore, and Dr. Surjit Kalsi from Noida. So I would like to thank all the doctors to take part in our quiz. Now, to enlighten us regarding today's topic, I would like to welcome our host, Dr. Sanjay Kalra, President, South Asian Federation of Endocrine Society. Over to you, sir.
Thank you, Ankur, and good evening, everyone. Today we'll be talking about something that we practice every day. We use antibiotics every day in our OPD, antimicrobials. But do we think about how rationally we are using them? We are aware of the basic facts, but then the facts have also changed in the past few decades. So today we'll be speaking on rational antibiotic use in type 2 diabetes, and I'll be speaking on behalf of Dr. Hitesh Punyani, who is a senior physician and diabetologist practicing in West Delhi. Diabetes is a known risk factor for infectious disease. We all know that. People with diabetes, specifically those with poorly controlled diabetes, are immunocompromised. So they are at risk of viral, bacterial, fungal infections. And we have seen that in COVID 19. The epidemic brought this, in very stark focus the fact that diabetes and poorly controlled diabetes, these were risk factors for developing COVID, risk factors for developing severe COVID, and then risk factors for succumbing to COVID. So we are aware of all this. It's not just COVID, it's each and every disease. There is a vicious cycle. When you have hyperglycemia, the uh, the person becomes more prone to developing infections wherever they are in the body. And once there's an infection, then there is decompensation of all the metabolic parameters. If the infection becomes very severe, then we end up with a catabolic state. The body has to spend all its energy in fighting the infection. It's not able to focus on anabolic processes, and it goes into catabolism. Once it goes into catabolism, then this vicious cycle starts. And the vicious cycle is hyperglycemia, catabolism, inability to fight infection, worse infection. Worse infection leading again to worse glucose control. So in diabetes, therefore, there is certainly a greater need for antimicrobial drugs, whether they are antibacterial or antifungal. There is also, therefore, a greater risk of misuse and potential adverse events. Polypharmacy is there. All the drugs that we use, many of the antibiotics and most of the antifungals, they do have drug-drug interactions with some of our glucose-lowering drugs. And it's possible that there is lesser efficacy. So many of us, myself included, sometimes instead of 5, we would want to give an antibiotic coverage for 7 days for a person with diabetes. And the excuse that we have is that you have poorly controlled diabetes, so let's give you the antibiotic for a couple of days more. In one way, this is nice. It may reduce the risk of development of antimicrobial resistance, but on the other hand, it can cause increase in cost, unnecessary increase in cost. So we should tread a balance. Some caveats we should be aware of. Do not, please do not treat asymptomatic leukocytosis with antibiotics. The leukocytosis may be because of multiple uh, pre-analytical or analytical issues. And one of the commonest ones is dehydration. So a person with diabetes who has dehydration, he will automatically have leukocytosis. So please do not treat asymptomatic leukocytosis with infection. Even if the patient badgers you, sir, please do something about my TLC. Please do something about my neutrophils or my lymphocytes. Please do something about my ESR, which is 28. The answer is that drink more water, fix up your iron, have a healthy diet, and we can check it again if you feel like after some time. Also, asymptomatic bacteriuria, please do not treat. Up till 5 pustules will be normal. So do not label everybody with asymptomatic bacteria as having a UTI. Of course, if there are symptoms, urinary symptoms, then we must treat. Secondly, when you're treating recurrent infection, now people with diabetes will come to you with infection and it can recur, it can come again and again. So if it is a recurrent infection, do take a past history of what antibiotic was given in the past. When you have this antibiotic history, you will know what to use later. What is the choice of antibiotics? This depends upon four C's. First of all, the putative causative organism. Based upon the organ system of the body that is infected, we know whether there are chances of anaerobic or aerobic infection. We know whether there is a chance of gram positive, gram negative, or mixed infection. So we choose the antibiotic according to the expected causative organism or organisms. Second is clinical features. Is there sepsis? Do you think there is systemic spread? If it is a local skin infection, a local antibiotic cream or antifungal cream may act. But if the infection has spread, then you will need systemic antibiotics. If the person has high grade fever, chills, rigors, severe leukocytosis, then intravenous therapy is in order. If the patient, as it is, has got acute metabolic decompensation and is taking intravenous insulin, then it doesn't make sense to give oral antibiotic. Then we will give the intravenous antibiotic. So, clinical features, the severity, that also has an impact. So, susceptibility of the causative organism, the severity of the disease, also other aspects, confounding factors, comorbid conditions, hepatic dysfunction, renal dysfunction, these will help in choosing the right antibiotic. Clinical pharmacology. What is the clinical pharmacology of the antibiotic? What are the PK/PD profiles? How frequently is it to be given? Does it impact the liver or kidney? Does it have drug-drug interactions? All these will also help us choose the right antibiotic. And do not forget cost effectiveness, because we have to be mindful of total cost for the patient. There is something known as the law of therapeutic parsimony. The law of therapeutic parsimony states that uh, minimal therapeutic intervention should be done as long as it achieves the optimal or required therapeutic outcomes. So, if you can manage with two antibiotics, there's no need to give three. If you can manage with a BD dosage, there's no need to give TDS. So, it depends from patient to patient. Now, when I was a student, we classified antibiotics as bacteriostatic and bactericidal. We still do that. But recently in 2019, the WHO introduced the AWARE classification, and 180 antibiotics are listed. And they are classified as A for access, WA for watch, and RE for reserve. So, see how we look at these antibiotics. The access group is the drugs which are effective across a wide spectrum of diseases. They can kill a wide spectrum of causative bacteria and they have less resistance potential. Examples are amoxicillin, ampicillin, the penicillin group, nitrofurantoin, which we use for UTI, doxycycline, a bacteriostatic antibiotic, gentamicin, clindamycin, and metronidazole. Metronidazole continues to be used for anaerobic bacteria. These have less resistance potential, so these are the 48 antibiotics we should use frequently. The watch group is something that we should not use lightly. This includes azithromycin, which these days is said to be the most misused antibiotic in the country. They also include cephalosporins like cefixime and ceftriaxone. Then the fluoroquinolones like Cipro and levofloxacin, and then other drugs like vancomycin and meropenem. They have a higher risk of bacterial resistance, and they are, of course, recommended for specific infectious diseases, but please do not misuse them. And these are the main targets of antibiotic or antimicrobial stewardship. The third group that we have, that is around 22 antibiotics, these are reserve group antibiotics. They should be used only as a last resort for multi-drug resistant infections. And this includes linezolid. If you're using linezolid for diabetic foot, please use it in the right dosage for the right duration of time. And do make sure that all other antibiotics have been used before you move on to this. Why this topic for today? We took this topic because Antimicrobial stewardship is important. Antimicrobial stewardship is important. It is our right, it is also our responsibility. And it is our responsibility to put in place a coordinated intervention which is designed to improve and measure or measure and improve the appropriate use of antimicrobial drugs. How can we do this? We can promote the selection of optimal regimens, which includes the optimal dosage, duration of therapy, and also route of administration. And if we are all mindful of this, then certainly things will move in the right direction. Now, as an independent practitioner, we may not have access to data, data uh, regarding the susceptibility patterns of various infectious organisms in your area. But you can easily find out whenever you meet someone from the neighboring medical college, from a neighboring corporate hospital, or from one of the reference laboratories in your area. Do ask about susceptibility patterns. They will be very happy to share this with you. The microbiologists, the laboratory technologists, they will be happy to share the information with you. Of course, do remember that hospital acquired infections are totally different from community acquired infections. Please remember this. So, if you are practicing in the community like I am, then the access group should be fine for us, and the watch group in case we get in trouble. However, if some of our colleagues are practicing in referral hospitals, then reserve group antibiotics, they will need this more often because their patients will more often than not, they will have hospital acquired infections. And then the access group is not going to work in them. So be aware of this difference as well, hospital acquired and community acquired. We had a short introduction today because I was looking forward to lots of questions. And Dr. DK Gupta says HB1C is 12, best treatment for type 2 diabetes at 12, and patient is already on vildagliptin, metformin, and glimepiride. Then I think we should give insulin. At 12%, basal insulin probably will not work. So if the patient is very sick, you remember that slide that we showed, the clinical features, the severity of disease for antibiotics. Similarly, for this particular patient, if your patient is in catabolic state, has a concomitant infection, then we would be better off continuing vildagliptin metformin, stopping glimepiride, and starting insulin. If the patient is very sick, basal bolus regimen, otherwise premixed twice a day. You can tell the patient that we'll give insulin for a few weeks. As glucose comes down, we will try to de-escalate the insulin regimen. So from basal bolus, we will go to, from 4, we'll go to 3, and maybe from 3 to 1 injection. And premixed, if we are taking twice a day, if glucose levels behave very well, we can always try once a day. Now, one question from Dr. Gangadhar Rath is, since fructose does not raise blood sugar. So actually, sir, it does. Fructose is different, glucose is different. Both of them are sugars. So what we are checking is glucose in the glucometer. That is why you will see all these fake videos, which are propagated by quacks. What they do is they say, I'll check your glucose. Now I will add glucose to the blood and I will check glucose, see it goes up. But now I added fructose to the blood and see the glucose came down. Now, it's not that fructose brought the glucose down. There was dilution. Earlier, there was 2 ml of blood. Now, there is 2 ml of blood plus 2 ml of fructose. So, obviously, the concentration of blood will go down to half. And that is why plasma glucose test will come down to half. So, fruits should not be taken in plenty. They will increase triglycerides also. So, fruits should not be taken in plenty, but they can be taken in moderation. It will also depend upon the glucose level of the patient. If the patient is very well controlled, then you can say 75 grams mango 3 times a day. But if patient is very poorly controlled, then we should focus on strict diet and exercise. And once the glucose is down, then the patient can enjoy the seasonal fruits. So this thing that our patients will also ask us, we should be able to explain. Fructose and glucose both are sugars. And when you are checking uh, plasma glucose, obviously only glucose will be checked. But that doesn't mean fructose doesn't have side effects. Fructose will finally create sucrose, and fructose will also lead to triglyceride increase. In fact, in the packed juices that we all drink, many of us are fond of that. In those packed juices, there is something known as high fructose corn syrup. This is artificial. It is made from corn. The corn is not like the Indian corn, the challi that we eat. It's The corn is created in such a way that it has very high fructose, and then they take fructose out of that and they add it to the packed juices. So these are also dangerous for health. Dr. Gangadhar asks about capillary versus venous. Yes, there may be a 10 to 15% increase in capillary glucose. So I used to find this problem in the OPD because we use glucometer for monitoring. Now patients don't complain so much, but earlier they would pick up a hue and cry. They would fight so much 20, 25 years ago. I want a venous test only. So how we explain is that from the heart, clean blood goes to your hand. This is clean blood, healthy blood. It contains more oxygen, more nutrients. Therefore, it contains the right sugar, the right level of glucose. That is why we test from the finger. But when this blood is going back, that is the dirty blood, blue blood, all the oxygen, all the nutrients, all the glucose has been extracted from it. Now what is going back is waste material. So when we check your glucose from the vein, it is waste blood that is being checked. So that is why the level is lower. So this is how we explain to our patients. We also tell them that the glucometer earlier was not approved by WHO for diagnosis of diabetes, but now it is. If you are using an ISO certified or an FDA certified glucometer, then that glucometer can be used even for diagnosis of diabetes. This is by WHO. The reference is the Heart D document. Heart D document. The only caveat is that 220 milligram they take instead of 200. Dr. Anshul Singhai from Bhilai says what to be preferred for cellulitis. So ideally, a triple antibiotic regimen would work. One of those is quite clear. It should be metronidazole. Now, whether you're giving oral or injectable, that is separate matter. That will depend upon the severity of infection and upon the systemic effect. The other two antibiotics, one broad spectrum and one focusing on gram positive, one on gram negative. So a traditional combination would be ampicillin, gentamicin, and metronidazole. But now, because the rate of resistance is going up, you might want to change the ampicillin to a cephalosporin, and the gentamicin, depending upon renal status, you might have to change the dose or stop it. So these are the common antibiotics which are given. Again, Dr. Anshul, if your patients are coming in with community-acquired infection, then MP Genta Metro even today or cephalosporin Genta Metro is a very good choice. But however, if the patient has got hospital-acquired infection, then you will need higher level antibiotics. Another question is appropriate time for fruit. So most of us tend to take fruit as a dessert after meal. We can tell the patient to take it 2 hours after meal. So ideally, everyone with diabetes should have a 3+3 meal pattern. So 3 major meals and 3 snacks. So the fruits can be taken as snacks. That would be better. It will prevent hypoglycemia. It will also minimize hyperglycemia. Dr. Anand Purandare asks about UTI. So in adults, sir, it is nitrofurantoin that I use. That is my first line. And if it doesn't work, then phosphomycin. Phosphomycin, 3 grams, one stat dose given at night with water. But for children, I am actually not aware because I don't treat. Uh, in my OPD, I use cephalosporins, and to be honest, it is Ziffy DT which I use when I have a child with type 1 diabetes. So that is what I use in the very young toddlers, 100 milligram BD, and otherwise 200 milligram BD. Dr. Vijayaraj Desai asks if saccharine has any role. So no advantage, but no specific disadvantage. If the patient says that they want to take, they can go ahead and take it. However, it is said that saccharine changes the microbiome of the gut. So it changes the bacteria that we have in our GIT, and we should tell the patient to use this in moderation only if required. Now that Dr. Anand asked this question, I am thinking of the antibiotics that I've used in the past 1 week in my patients. So I've used a lot of coamoxiclav, and Flemiclav is one good brand. I've used it in diabetic foot. I've used it in bronchopneumonia as well. Then I have used azithromycin. I think that is the second commonest. That I have used for URC, upper respiratory catarrh. And another drug that I have used frequently is NFT, nitrofurantoin, that is for UTI. And if I put all these three separately, together, I mean, and then I think of antifungals, then I have used lots and lots of fluconazole in my OPD. Now, earlier, 25 years ago, you would give one tablet of fluconazole, 150 milligram, and the fungal infection would vanish. Like it would be magic in less than a day. But now you have to give it for 7 days, 10 days. And sometimes fluconazole doesn't work, then I have give itraconazole as well. So these are the drugs that I used frequently. And like I said, for children, I think it is Zifi DT, which I use. Okay, Dr. Rajdeep Biswas asks, do you use systemic antibiotics before cataract surgery in uncontrolled diabetes? Uh, so I do not prescribe, but the eye surgeons usually prescribe eye drops. So they give antibiotic eye drops. And I don't think our ophthalmologists in Karnal give systemic antibiotics. Usually it is topical that they give. If it is uncontrolled diabetes, as it is, the cataract surgery should not be done. So no elective surgery should be done in an uncontrolled person, in a person with uncontrolled diabetes. We should counsel the patient. And we very clearly say, sir, it is your eye and we can't replace it. Let us get your glucose under control for a week or 2 weeks, and then we'll give you then we'll take you up for surgery. Sometimes we have people who come and say they have a genuine complaint problem. I've come from abroad, or I'm working in the army. I've got vacation just for 4 days. I want to get my mummy's cataract done. Then we give them insulin coverage if the glucose is very poor, and we counsel them that they should take insulin for a few days before surgery and also a few days after surgery. That is at least until the healing is complete. Dr. AR has a right point. Roxithromycin is a drug I have used many decades ago, but it is a good drug. And Dr. AR uses roxithromycin instead of azithro. It does give good results. And all patients got used to azithro since COVID days. I fully agree and empathize with you, sir. That is a good choice also. Cefixime plus ofloxacin is a good choice. Ofloxacin, I think we should avoid in children. If Dr. Anand is speaking about children, in adults it will be fine. So abdominal infections, infections of the gynecological tract, infections of the urinary tract in adults, cefixime plus oflox can be given, but not in children. Oflox is contraindicated. Also, this combination is not approved by the DCGI. So it would be a good idea maybe just to stick to only cefixime. Dr. Sanjay Shihora asks, hi Sanjay, any effect of sucralose on glucose level? No, none. You can use it safely. Only thing is there are some studies, like I said, which say that the microbiome changes and it may predispose to obesity because the anti-obesity bacteria or the anti-inflammatory bacteria, they get killed when excessive doses of sucralose are used. However, most of our patients don't take too much of saccharine or sucralose. They'll just take one tablet once in a while, and you can tell them to take it in moderation. Just define moderation for them. Thank you, Dr. Rajdeep, for being with us, and thanks, Sanjay, as well. It's nice to learn more about these antibiotics, and we keep on learning. So, like I said, speak to the laboratory technologist or the microbiologist in your area. Speak with colleagues as well, and try to follow the law of therapeutic parsimony. So, minimum antibiotics. Yes, ofloxacin, levofloxacin. This is from Dr. AR. We should avoid in children, in the young children. I know that these drugs are being used, but there are safer antibiotics. So cephalosporins will be safer for these children. In general, we must agree, all of us, that in our country we are overusing antibiotics. That is the tragedy. For the people who seek healthcare, who come to our clinics, we overdose with antibiotics. And the ones who don't come to us at all, they are underdosed, because they don't come, like they come in with such bad diabetic foot or something that you feel so sad. Had they come earlier, had they come a week earlier, we could have given them very good treatment with much, much less cost, with much less antibiotics. So this we all have to admit that we are overdosing our patients on antibiotics. I am actually reminded of what happened when I came in practice. This was the year 2000. So I came back to Karnal and I started my endocrinology clinic. It took time to develop. So I remember getting a couple of patients with fever, and whatever test I wrote, whatever medicine I wrote, that I do not remember. But then I had one physician assistant, a compounder. He had come from a village, so he saw me treating one patient, two patients, three patients, and then he picked up a lot of courage, mustered a lot of courage, and then he comes to me and says, "Sir, आप डेक्साजेंटा नहीं देते क्या in fever?" So that was the staple treatment for fever in the villages: dexamethasone plus gentamicin mixed and put in one syringe. So now I remember that physician assistant, his name was Manjeet. I'm sure he would be doing well somewhere in life. So that was his treatment for fever, Dexagenta. And he was quite surprised that I was not aware of it. So it's great. And thanks, Vinayak, for being with us. It's great being with everyone. Uh, Questions that I realized for myself is that we need someone from pediatrics also to speak to us not only about the specifics of pediatric diabetes, but also about the specifics of pediatric antibiotic usage. Uh, Another question from Dr. Rath. Yes, sugar-free tablets can be given with limitation, with in moderation. So we tell the patient you take them as per taste, but try to get alternatives for taste. Like let us say you want tea and you want the tea to tickle your taste buds. Instead of sugar, you can try sugar-free. But instead of sugar-free, you can put in a lot of cinnamon. The Hindi word is dalchini. Or you can put in a lot of saunf or elaichi. So these are also tasty things. They are spices. So you tell the patient, we have so many spices in our kitchen. Why don't we use them? So you can use a lot of dalchini, elaichi, or saunf, and then you get used to the taste. You begin enjoying that actually. Another thing to teach them is don't put the sugar free while the milk or tea or water is boiling. You take the tea or milk out of the off the gas, off the burner. Once you've put it in the mug, then you can put in a tablet of sugar free, whatever brand you are using. This way, there is no bitterness. Otherwise, if you put it in boiling water, then the end result or the end taste is there's a slightly bitter taste to it. Dr. Sanjay asks if long time low glycemic foods which are packed in containers have better than regular balanced food for sugar control. Yeah, there's no harm. If the glycemic index is low, then you can have these foods which are packed, but also be aware of salt intake for those with high BP. And a comment from Mr. Anand is that Dexagenta is so common in rural India. Yes, all over. And the patients come and ask. Yes, that is true. And it is just taken as part of therapy. Just like other treatments are the colored glucose and the non-colored glucose for takat. So you get a, and I'm sure many of us will be smiling as I speak. I myself am smiling and laughing. So these are treatments which the patient expects from us. What I do instead of this, instead of giving the red glucose and the non-colored glucoses, I tell them, we know how to give the glucose. We can always do that. But why don't you take this Enerzel drink? And if you don't have diabetes, you have a choice as well. You know, it can be orange colored and it can be blue colored also. So you can take that energy drink, wait for 15-20 minutes. If you're not comfortable, then certainly we'll give you the injection if you need it. And one other tablet, if the patient is very like anxious or frustrated or angry or complaining of non-specific uneasiness, ghabrahat, then is to give us mouth dissolving tablet of promethazine. So we give that along with the energy drink, and usually patients are fine in half an hour. Dr. Nitin Narula asks about vitamin B12 and D. So injections only if the patient has pernicious anemia, not otherwise. And tablets and dose, I prefer sublingual. So sublingual 1500 microgram is there once a week, once a month, or a daily multivitamin. But there has to be a reason. You should know why you are giving it. Are you giving it because of pernicious anemia? Then injection is required, or sublingual tablet is second choice. Or are you giving it because the patient is strict vegan? Vitamin D, there are multiple forms of absorbing of vitamin D, and anything with nanotechnology, a good syrup preparation or a good capsule will be fine. Take vitamin D from any reputed manufacturer. A specific question about stevia. Yes, this is safe. It is safe. It is safe in pregnancy as well, Dr. Tarakjo. So we can advise to children, antenatal women, and adults. Just tell them to take in limits. That is for everybody, so that they don't become addicted to the taste, and also their microbiome remains healthy. So with this, we've had lots of questions and comments, and I realized that these topics are more relevant for us. The topics like managing infections, giving antibiotics, UTI, and these are things that we face every day in our practice. So that's what we'll be focusing on this year in Diabetes Essentials in our third season. Next week, we'll talk about the prostate. We'll talk about the prostate and diabetes. So let's see what questions, what comments we have. And then after that, we'll talk about reducing renal risk. How do you reduce renal risk in persons with diabetes? So with this, I'd like to thank everybody for a very engaging discussion. And I'd like to hand over back to Mr. Basu.
Thank you, sir. I think truly the questions that we got and the answers we got from you is very encouraging for us because the number of question answers were higher even today. That clearly shows that the selection of topic done by you are very relevant for the daily practice. And I thought one thing to add during the discussion is that many of our physicians are being confused. I would say misled with a lot of pharmaceutical organizations who do not follow the DCGI regulations. And I want to inform them that last 4 5 years after the Kokate committee, there are many drug combinations which have been irrational in India, have been put into ban, but still many companies, especially we don't have regulated bodies in India which is monitoring and regulating the pharma industry very well. So they continue to get some state approvals. Basically, they don't have DCGI approvals. They continue to get some state approval. That's why I see many of the doctors still writing combinations of antibiotics specifically, which are have not been used in anywhere in the world. It's been only used in India. That actually happened when the entire India was riding the tide of combinations and combinations and combinations. Certainly, this last 10 years there are rationalization in terms of uh, uh, drug authorities selecting the right combinations and giving only approvals to them. But still, in India, I mean, we have loopholes and people are getting state approvals and managing it. I'm sure. I think we also try to find out some space in our journey with Dr. Sanjay Kalra and especially in Diabetes Essential that we will try to enhance the awareness level of uh, drugs which have been not been approved currently and but still been sold. I think that also we will try to find out because there are a lot of combinations, especially in vitamins and multivitamins and antibiotics, which have been. I mean, this is completely rational. There is no rational to this. I felt it saying that because we have been doing this journey for last 3 years and there is no interest. I think there is no hidden agenda or interest. I simply find that as a human being we have the rights to get right treatment and good medicines. With this I sincerely thank Dr. Sanjay Kalra uh, for being with us and giving his very important times and getting question answers covered in our journey with Dr. Sanjay sir. With this we thank you and good night and Jai Hind sir.
Jai Hind.